I think what our purpose here today is to really address this question of bottom-up change from the perspective of students. But what we want to say is that we're just going to use the word students. We're going to talk about the concept from the perspective of students. But really, in many ways, we're trying to talk about how our framework and what we're going to present today is representative of the things that you can do to empower those who are closest to the patient, who are on the front line, who aren't in formal leadership positions. We're going to say student a lot. We're going to have student presenters, but we hope that you can see how, in many ways, there are similarities between what the student initiative is and what the initiative from the perspective of those everyone else who's not at the top running the show is. So, but before we get going, I really want to introduce our wonderful students. We've got 4 of them who have volunteered to present their own experiences in doing real quality improvement projects, and they're really the important part of today's session. So Jorn and I are going to do our thing and get out of the way quickly so that so we can hear the really good stuff. So starting on your left, we have Heidi Hansen from University of Jönköping. We have Ashley K. Childers from Clemson University. We have Claire Rivers from University of Edinburgh, and Jess Lang from University of Manitoba. And so they've got some really interesting things to say, and I'll let them introduce their own projects in just a moment. So just a quick overview of how we're going to run this session. As I said, Jorn and I are going to do our thing and get out of here because we want to get to them. We'll take about 15 minutes to present our framework. Then we're going to get to their student project presentations. And then we want to do an interactive Q&A session. We hope that you'll have some questions for us, but we also have some questions for you. We're going to ask you to, we're going to try and take advantage of all the brains in the room and ask you to help us figure out how to involve those on the front line in making change. So we're going to pass around some papers and baskets and ask you to bring those questions to us. We also want you to stick around and ask some questions of us and of the students. So without any further ado, I'll turn it over to Jorn to explain our framework.
I think healthcare today have some dilemmas, and here are 5 of them. How can we make change to something positive that makes it to an opportunity and a positive challenge? And very often it can be even more difficult if you are not in a leadership position. But does it have to be like that? Can't it be the other way, that it is the employees that make the leader instead of the leader making the employees? Change can be bi-directional. It may start from the top and trickle down, but as I just said, it can also occur from the bottom up. Some of the most inspirational and transformational changes in healthcare have really come beyond the traditional hierarchy. Today, most changes initiatives are developed by and directed from the top of the hierarchy and pushed down. We are put into ideas that someone else have created. Very often those initiatives are created and mandated without input from the broad base. We don't have the right relationships. We don't understand the context totally, but we should still do the change. And sometimes we are not tapping the full potential of our workforce in the workplace. So Alexi and I, we asked ourselves, how can frontline workers, residents and health professionals, students motivate or participate in improvement efforts? And what circumstances have to exist for improvements to be driven by people not in formal leadership positions? And how can healthcare foster a culture where bottom-up change is not only welcome, but encouraged? Why is bottom-up work valuable? How can it support top-down change, and vice versa? And how can we create value together? And can the students and, of course, the frontline people be the resource we really have to encourage and energize?
So those are a good set of questions to help us answer this question here. I mean, we're going to try and answer these questions on our own, but these are the questions that we want to pose to you. We want to challenge you to help us build the model, and that's what we're going to do towards the end of the session. And before getting to conveying the messages, I just want to say again, we're going to talk about students, but we want to talk about just people who change driven from the bottom up, and we've seen this work in real life. Just recently in the U.S. presidential election, we saw that grassroots change created an incredibly powerful network that was able to actually, hey, make change. I didn't even realize that. So I think what the main messages we're trying to convey are these. One is that students are young, they're energetic, they're idealistic, they want to improve the professions that they are newly entering. They want to model that behavior. So there's a great deal of motivation, but unfortunately not a lot of outlets to act on that information. And that's true not just for students, but for all types of workers who aren't quote unquote empowered in leadership positions. So we want to create a model that will allow those at the bottom to drive change. And then why does the healthcare system, why is it in the healthcare system's interests to create that kind of culture that allows change driven from the bottom up? And really, there's a couple of points. One is that, when you've got more brains on the case, it's got to be a good thing, right? I mean, it's just more intellectual horsepower. But then imagine a whole new generation of professionals who have the motivation, the improvement mindset, the training that tells them that quality can be a business strategy, that safety can be a driver of change, that system science and everything else that we're learning here this week at the National Forum are attitudes rather than side projects. That these are things that pervade our entire work. Imagine if the healthcare system had everybody from the top to the bottom sharing those same ideals. That's a very powerful situation. So hopefully it will allow us to deliver what is our primary goal, is delivering high quality, premium patient care. So let's get everybody on board to do that. So those are the messages we hope to convey. We created a little bit of a framework which Göran will share with you now. Oh, sorry, no, I forgot about this one. Okay, so this is basically what we're going to do for the rest of the session.
So let's go.
You'll see it.
We thought that the key question is the need of developing value for the patients. And we have learned a framework and a language how that can be done through the idea of a microsystem. And we talk about 5 Ps, and you see them all here: purpose, patients, people, processes, and patterns. But nowadays we think it's very important to add 2 more, and those are then passion and perspectives. And the last 2 we think are very important in the perspective that we talk today about how can we help and support and make students be a part of our work. So behind those first 5 Ps there are questions. We don't have to answer all of them today, but questions that the students have to be aware of and be a part of and answer if they should feel that they are really a team member. And again, how joyful is the work, and are there a chance for them to put the understanding into a new perspective? So, what is the purpose? Well, the purpose is an effective microsystem should have clearly defined goals for its works and have the patient as the primary goal, how we develop value for the patient. And then we come to the patient perspective. And Alex, what do you say about the patient perspective?
Sure. So the patients are a very important component of any microsystem. Of the 5 Ps, they're probably the most important because they are the people for whom this microsystem exists. They're the ones who receive the care that the microsystem produces. So the system must be attuned to their needs and must understand what those needs are and if they're being met. So where does a student or a frontline worker fit into improving the meeting of needs that patients have? Well, so with their passion, with their extra time, with their exuberance, students are great people for gathering information about whether or not patients' needs are being met and where they're being lost in the shuffle. Students have a lot of time, and so they can spend time with the patient, and they have to listen because they don't have yet those sophisticated ears to know what they're supposed to listen for and not supposed to listen for. So they have to listen to everything, and they have to really absorb everything. And they can spend that time with the patient to know, hey, is this person getting what they need? And if not, how can we fix it? So that information, that data is so important to any improvement project. And as I said earlier, any person on the team who is concerned about the care that the patient is receiving is, of course, a great addition to that team. So let's take advantage of that. So who are the professionals? So in a microsystem, there are people who are involved in the delivery of the care that the microsystem produces. And these are everybody. These are the providers, these are the staff, these are the administrators. It's also the students. And what's interesting about students is that they offer a, well, let me just back up a second and say, the typical view of a student is someone who takes a lot, someone who is there to learn and to receive. But I think we can create a new conception and say that the student is really there to contribute and be another one of the professionals on the team. But hopefully they have an additional mission, which is they try and learn something in the process of contributing to that microsystem. So they can give and they can take. But I think the other thing is that a student is an untapped resource. A frontline worker is an untapped resource who has area-specific knowledge, educated eyes, has a great perspective of, that's really up close and personal with the patient care process, and that's something that should be taken advantage of. And then finally, if you really include those on the front line, students, everybody else who is not typically empowered, and you do empower them, they feel incredibly invested. It's a great way to raise joy in work. And then the processes are the things that actually make up the system. How is care delivered to the patient? And where does the student fit in here? Well, I think that the interesting thing here is talking about perspective. And this is really true of anyone who is not in an empowered position, quote unquote, formal leadership position. These are people who have, again, up close and personal information about the process. They have a new perspective that may not be entertained when trying to figure out how to improve the system. And so that is a perspective that can be incredibly valuable to the improvement process. And then you have people who have time to investigate how to fix the process. So if I'm a medical student always pre-rounding in the morning on my CHF patient, and I find that they don't have a daily weight every morning, it starts to get kind of annoying. And I wonder, well, why don't they have a daily weight? I have the time to go figure out where is the breakdown in the system, and I can talk to all the people who are involved in that system, and then bring it to the attention of people who can actually change it. So you have in students someone who has a fresh perspective and time to figure out how things go wrong.
How many times haven't we said that, oh, very warm welcome, and we are so happy that you come here, and please help us, give us all the things you see directly so we can learn from your new eyes. And I think that this concept of patterns really capitalize the need of that perspective. I think that students really see our patterns, and sometimes they maybe should sketch our patterns and make pictures of how we work, what we are achieving, what performance we have, and give it to us, because it's within the patterns all the habits are hide. Maybe we should, instead for talking about barriers now, Alexi, why don't we introduce the students and come back to the barriers?
We don't like talking about barriers.
No, we don't.
All right, so why don't we turn things over to the students, and we'll come back to some of our thoughts on barriers and a couple other things, including we want to give you a little bit more information on the Open School. But first I'd like to introduce Claire Rivers, who is a medical student at the University of Edinburgh, and she did an interesting project on the surgical pause. So Claire, when you're ready.
Can you hear me? Yeah, grand. Hi. So as Alexi said, my name's Claire Rivers. I'm a fourth-year undergraduate medical student at the University of Edinburgh. And before I tell you sort of about my project and how I think students fit in, I'll just give you a wee bit of background about what's been happening in Scotland recently. Back in January, the Scottish Patient Safety Programme was set up and spread out throughout all of our hospitals in Scotland, and it aims to improve patient safety by improving all of our processes. By doing that, we're looking at sort of the healthcare, and we're dividing it up into different areas. So we've got medicines management, general ward, critical care, and we've also got the perioperative stream, which was where I was involved in. And the surgical pause is one of the drivers of this. And what it is it's the checklist that was spoken about this morning in the keynote speech. And it's done prior to knife to skin once the patient is anaesthetised. And it's basically a checklist making sure that you've got the right patient, that they're there for the right procedure, at the right site, that they've had their DVT prophylaxis, antibiotic cover, the works. And it has been shown to reduce errors and complications by improving teamwork and communication within the operating theatres. So this is just a copy of the checklist that we're using in the Royal Infirmary in Edinburgh, and we just adapted the WHO one. I also have to say here, didn't choose to do a project in patient safety. I wanted to do a surgical project, had no idea about patient safety, had not very much teaching on it up until this point, and I kind of got thrust onto a consultant who didn't really want a student. And it's actually worked out really, really well for both her and for me, and that I'm now doing lots of work for her. So my role was, I basically had a 14-week research project built into my university curriculum, and I did an audit on the use of the surgical pause in our 5 general surgery theatres from its implementation in May up until the end of August. And so I had to gather data on compliance rates in each of the theatres, also for each of the surgeons, so that we could target those surgeons who aren't using them and kind of persuade them to start using it. Observe how it's being used, because how it is used is differed throughout the different theatres, and also gather staff opinions. Because I was spending the best part of 14 weeks in the theatres, I was answering any questions that frontline staff had, such as nurses, ODSs, anaesthetists. I had to analyse the data and present it, not only for my university project, but for all the staff members who were involved with the various streams in the Scottish Patient Safety Programme in Lothian. I was also there to help give an outsider's point of view, question why things were done, and kind of give a fresh perspective. I benefited immensely from this project. I got 14 weeks to spend in theatre, getting to see all sorts of procedures. I got to see so much, which was great, because I'm really interested in a career in surgery. I developed a new interest in patient safety and quality improvement that I wouldn't have developed if I'd done another project, and it's something I've become quite passionate about. I've learned lots of valuable lessons from senior staff members, not only about patient safety and quality improvement, but also what will help to make me a better doctor when I graduate in just over a year's time. I've made lots of new contacts. I've got lots of people now who are on lists of potential referees for my CV next year, so they'll probably get lots of phone calls. And also I've now got lots of new experiences that will look good on my MTAS form, which is how we apply for our junior house officer jobs next year, which will set me apart from all my other students. I'm also, as a result of my initial report and project that I did this summer, I'm also getting to present at the International Forum on Quality and Safety in Healthcare in Berlin, and there's also a possibility for me to publish my initial report. And also the main one is I got to come to Nashville, which is a massive bonus for any students. Thank you, Alexi, and you're in for that. How the project benefited from having a student, or me, was I had lots and lots of time on my hands to gather the data, to go back, double check it, and ask any questions, and they really, really did benefit. And because I was enthusiastic, I was hardworking, I was thorough. I was also able to get the true opinions from the staff about what they thought, especially from the nurses. They were able to tell me which consultants were doing it properly and which ones weren't, because they knew they wouldn't get in trouble. And they were also more likely to give me their opinions of it, of whether or not they thought it was going to work. Because I wasn't a senior member of staff, I wasn't going to get them into trouble or anything like that. I was just going to take on board and then use it. Also, because I had a university deadline, it meant that it gave me extra pressure to get work done. It meant that I worked extra hard, and it meant that everything got done on time. And also, other streams saw the benefit of somebody with time on their hands. For example, general medicine have now recruited a junior doctor to help them gather data, because they've realized how important it is you need somebody who has the time to be able to pick up that data. So as Joran and Alexei were talking about, they're talking about the 7 Ps. And so the data that I gathered will encourage other people to use the surgical pause because they'll be able to see the benefits of it, which will therefore increase patient safety. We're great for gathering data. We can do it. It's easy. It's the donkey work. We just use this for the donkey work. We don't mind. And data does need to be gathered to measure improvement. And it was also really empowering to know that I was helping to make a difference, and a real difference that you can actually see on paper with complication rates falling, and also to be part of a professional team rather than just a student team and feeling really valued. If a student's passionate about something or think they can get something in return, like a publication or a presentation, we'll give it our full attention and time. We're good for being brought in once a practice has been implemented. So we may be a bit harder to maybe try and implement something, but really good for then assessing it, looking at the problems, looking at how it can be improved, looking at rates of use. And as I said before, we're useful for those really simple, tedious tasks that nobody else wants to do, because we're hoping we'll get something out of it at the end of it. And I went in with a very simplified view of the health system, and that's really, really helped, because the health system just gets too confusing and too complicated. And I think we need to bring things just back to basics sometimes. So for takeaway points, if you're a student and you want to get involved, only do it if you have time. You'll have, especially as medical students and other professions, you have so much else going on within your curriculum that you need to make sure you have time to take out to do this. Get involved in a project where the data is easy to gather. I discovered that once I finished my project, the data I was needing to gather was locked away after 5 o'clock in the evening. By the time I finished my clinics, whatever, after 5 o'clock, I couldn't access it. And don't be scared to ask for help. You've got tutors there who are there to help you and to teach you and to use them. If you're wanting to use students for a project, we're really good for analysing data and gathering it, doing the donkey work. We're scared of consultants. Don't ask us to tell them what to do, because we're going to be asking for them for a job in a few years' time, and they might not look on us kindly. And also be aware that we have university deadlines if the project is not part of our curriculum, and they will come top priority to us because we don't want to fail. So, thank you.
Thank you very much, Claire. That was a wonderful presentation. And I guess what I should have said before introducing our first student is what we asked them to tell you about. And really what we've asked them to tell you is 2 things. One is that we wanted them to say, well, 3 things. We wanted them to tell you what their project is, to give you a little bit of context. Then we asked them to tell you what were they able to give to the project because of their unique position as a student, with time, with a different perspective. What were they able to give? Then we also asked them, can you tell us what were you able to get that was useful to you? So Claire was talking about, for example, she got to meet all the people in the field that she wants to go into, and she got to make a publication out of it. So what did you give? What did you get? And this harkens back to the theme that we were talking about earlier, which is that students can play a dual role. They can contribute to the microsystem, but also get some education out of it. So now I'm going to turn it over to Ashley Childers, and she's going to talk about her projects in industrial engineering.
I'm
Thanks,
kind
Ashley.
of a bad one to follow Alexei's speech here, because I'm a bit different since I'm not a medical student. I am a PhD candidate at Clemson University. It's in the top left corner of South Carolina. And I will say 2 things. Since I am not a medical student, I may misuse medical terms. So I apologize in advance, but I'm here to learn. I also think that it's important that you realize that a part of industrial engineering is quality, and my master's research was in quality. So there's a lot of overlap in what I do and what you guys are trying to do with these improvement projects. And so I'm really appreciative to Alexi and Yoram for the opportunity to talk to you guys and maybe enlighten you a bit about what industrial engineers do. And they've talked about how the students can provide a different perspective. And so I'm maybe hoping that not only are you getting my perspective from a student's point of view, but you're also going to maybe learn a little bit about industrial engineers. The best definition that I can come up with are that industrial engineers are in charge of designing, installing, and improving complex systems. And so this isn't just this isn't just a piece of the puzzle. We look at systems that integrate people, machinery, processes, flows, equipment, etc. And so the buzzwords that you're going to hear are improvement and efficiency and quality. And it's very important that industrial engineers are user-centered. There's also a lot of overlap in what you guys do. A lot of people think that industrial engineer means manufacturing, and that's not necessarily true. Our undergraduates at Clemson University learn simulation. We learn inventory control. We've got people that do human factors and ergonomics, a lot of facility layout. We do transportation, system design. We do probability, optimization. We do a lot of statistics. We're Six Sigma certified. And again, quality and process control are the things that I think you guys are all most familiar with. At the graduate level, some interesting research that's going on includes determining optimal physician panel size, scheduling, determining the best treatment plans based on certain probabilistic models. At Clemson, we have some folks that are working on using technology to reduce complexities in medication distribution, and I'm working a little bit on evacuation, which I'll talk to you a little bit about. One quick thing that I would say, so they wanted us to address our passion, and the nice thing about industrial engineering is that normally you can see the improvement, and it's nice. So I can say I saved someone's X amount of dollars, or I saved someone so much time. I would interject, though, that I really enjoy doing this research because it's nice to feel like I'm doing something that makes a difference. And I don't mean to be cheesy, but I really have enjoyed working in what I call healthcare land because of this. It would have been nice to be a doctor or a nurse, but I learned that I pass out really easily when I see blood. And that's funny, but it's worse because it goes beyond that to include medical equipment or people in pain. I immediately go down. So I'm working on 3 separate projects. One includes my PhD research. The other is an initiative to get undergraduates involved in research. And then the other I'll talk a bit more about because this fits the idea of what Yoram and Alexi are talking about with bottom-up change. So real quickly, the assumption when we have an evacuation is we're going to transfer all the patients. Well, we're asking the question, what happens if you have some circumstances that limit the amount of patients that you can choose? I want to know, is there an optimal and ethical objective that we can choose to say, okay, you get to go, and you get to go, and we're going to do it in this order. And who are we going to leave behind? And who are we adding risk to by moving? Would it be better to leave them and shelter them in place? We've developed a Markov decision model, which I think is super cool. We've got a dynamic program that will run through a list of different parameters and give us a prioritization schedule. And then I have a simulation that will, based on those inputs, tell me how many people got out, how long it took, who died, who didn't, etc. It's right now at a very theoretical level, and so if you are interested in evacuation at all, I would love to talk to you afterwards. I have no problem with the shameless plug up here. The other project that I'm doing involves the movement of information and processes through the perioperative department at Spartanburg Regional in Spartanburg, South Carolina. A typical IE problem would be to say, okay, let's simulate the process, let's find out where the bottlenecks are, what can we improve, etc. Well, so we're going to take our typical IE problem, though, and then work with the nurses and physicians at Spartanburg Regional to identify the flow of information and what's going where. And if I need to tell you this, are you sure to tell that person, etc. And where does the information stop and what are the reasons? Is it a lack of trust or power, etc. And so these are the things that have been really exciting for me. I will say that I am very happy to be at Spartanburg Regional, again, because I think it fits this bottom-up idea. In my first meeting, the nurses, physicians, CEO, COO, et cetera, were all there and working together to talk about a recent project they had done. What had they done? What was great? What was wrong? And how could they move forward? And it's a very industrial engineering concept to have everybody working together. Further, they are very interested in what students have to say. And finally, they're the nicest to me when I pass out. They get me water and chairs. And they want us to mention the contributions that we have. The nature of industrial engineering is such that these projects are longer term. So I've been working in this evacuation research for about a year now, but I can't tell you today I've saved X amount of lives. It's just not there yet. But what I have been able to do is introduce this concept of industrial engineering and let people at these different facilities know that when they have a problem with scheduling, hey, that sounds like something an industrial engineer could do. So I've really appreciated the chance to do that, and I'm able to offer a different but supplementary approach to some of their problems. And the other thing that I think I'm able to contribute is, or at least because I'm a student maybe, I'm able to work with these nurses and physicians, and I'm kind of a facilitator for this bottom-up change that we're here to talk about. And in my career at Clemson, one of the great things that they do is require lots of different projects with lots of different types of clients. And so even as an undergrad, I've been involved in these research projects. And so I've tried to tailor this a little bit based on my experiences from my undergraduate work, some work in inventory, and then the lessons I've learned from working in healthcare. The most important thing, even though it seems pretty basic, is that it's very important to ask questions. Not only does that obviously help me learn a lot, but I find that when I continue to kind of ask why, well, why do you do that? How come? Sometimes I realize that maybe we don't know why, and sometimes there's some redundancies or silly things that we're doing for no reason. And so it's also helpful to the people that I'm interviewing, even though probably annoying. It's also important to be aware of the research that exists, and so that's another reason that I've landed myself here. It's very self-explanatory, I think, but it's really important that you're willing to teach and be taught. And I think on both sides, from the folks that are working with students and students, you need to realize that neither of you have all the answers. And this is why we're working together. It wouldn't be research otherwise. And so if you are interested in working with student researchers, I would say the following. It's very important to make sure that you give your students the adequate resources that they need. Whether it's time, whether it's meeting space, whether it's data, etc. It's really important that based on what you give them, then you understand that there are certain expectations for what that student has to do for you. I think it's very important to outline these expectations and set goals for deliverables, etc. I'll be taking questions at the end with the rest of the students. And again, if you like evacuation, so do I. So I would love to talk to you afterwards. Thank you so much for coming, and enjoy the conference.
Thank you so much, Ashley. That was a very interesting presentation, and it's great to get a different perspective, and that's hopefully what we're really trying to talk about here, is that we should leverage all the different perspectives and take that information and hopefully use it to our benefit. Our next presenter is a student from Sweden. Her name is Heidi Hansen, and she is going to talk about her project on care for buttonhole boutonniere deformity, which is something that I have no idea what it is.
Well, hi. As you know, my name is Heidi, and I'm an occupational therapist student from Jönköping School of Health Sciences in Sweden. I don't have a PowerPoint presentation today, but I did a poster, and it's over there. And on this poster, it's a little bit more information than I'm going to tell you now. So afterwards, you can come down and just talk to me and look a little bit of the poster if you want to. When I was going out in my last clinical fieldwork, I was asked to take part of a project with the aim to involve students in a clinic's quality improvement work. And I said, yes, of course. And thanks to that, I'm here. What we did during this project was to improve the treatment guidelines for patients with buttonhole deformity. Do everyone know what that is? No. It's kind of when the finger gets stuck like this, because the tendon slides down here, and it's kind of stuck there. So that can be a problem when you're using the hand. And we didn't choose this subject by ourselves. It was told when we come, this is what you're going to work with. And in this particular case, it was really good because we didn't really have any time to spend on choosing the subject. So we started up by looking for information, and we started with literature and articles. And we wrote everything we found, we wrote it down. And after that, we started to interview the occupational therapists and the doctors or nurses who was involved in the treatment as well. We found as much information as possible about how the treatment came into the system and which way it was going to take after that. When we gathered all the information we needed, we sat down and made a flow chart just to make it easy for everyone to see where the patient are now and where it's going. And it's easy and a very good way for the patient as well to see, here I am, and that's where I'm going. That's a very good way of making things clear about the treatment. We was working on this project for 5 weeks, and we did this beside the patients. So we had to do it about over the other work we had to do. We presented the guideline afterwards, both in the clinic and at the school. And after we left the clinic, the occupational therapists, they finished the guideline and found evidence for the treatments and the things we've done there. So, doing this was a good way for us as a student to feel that we did something important. Because when you're a student, you sometimes feel like you're doing lots of things and you don't really know why, but you do it because you have to. So this is really nice, doing something that you know they're going to use in everyday work. And it was quite a good way of have a good look of the whole system, where the patients are and where it's going. And I also got some kind of an expert of this certain patient group. And it was a good insight of everyday quality improvement that was done at the clinic. So it's really nice doing this. What did we help them with? Well, we saved them lots of time, of course. They didn't have to do it. They put it on us, and we were gladly to do it. So that was a little bit about my project, and afterwards you can just come down and talk to me if it's anything you wonder about. Thank you.
Thank you very much, Heidi. And please do go visit her at her poster afterwards. That's a very interesting project. Thank you for your presentation. Our final student is Jess Lang. He's a pharmacy student at the University of Manitoba, and he did a project on medication reconciliation. And so he's got an interesting perspective. So let's just cue up here. There you go. All right. Thank you, Justin.
When Heidi first came up here and she's like, oh no, I don't have a PowerPoint presentation, I was thinking, I don't have a poster. Like, come on. My project was just over summer 2008, so a lot of my initial findings haven't yet been published, or I haven't had a chance to get around to publishing it. Although the report has been filed, having a poster would have been phenomenal. So I'll get on that just to catch up to you. Again, my name's Jess Lang, and I'm a third-year pharmacy student at the University of Manitoba in Winnipeg, Manitoba, Canada. The reason the other banner's up is because of a personal plug. I'm also the University of Manitoba Pharmacy Student Association's co-stick. So I've been trying to work closely with a lot of with the other co-sticks from other faculties. And together, we're hoping that at some point we have an interdisciplinary background that where we can actually start as students, and then we'll already have that kind of that camaraderie once we reach professional practice, and that's what we're working on right now locally. My project kind of concerns the Health Sciences Center in Winnipeg. I was a pharmacist assistant working there this past summer on the studentship from the Canadian Patient Safety Institute and the Manitoba Institute for Patient Safety, using the ideals set forth by Safer Healthcare Now. One of the big things that they were pushing was medication reconciliation, and obviously that came from the hard work at the IHI, and that's why I'm here today. So a couple learning objectives. Today I'm just going to talk about how I got involved, what I learned, what I contributed, and what I feel that my impact really was by the end of the day, and also the impact on me as a result of working on the project. So first of all, how I got involved. As I was telling the students at the orientation yesterday night, first of all, I met a doctor, Dr. Dean Creelars, who's working in sports medicine. I know that's not medication reconciliation affiliated, but just bear with me. That was my initial exposure to research experience. I was working with athletic supplements. We were learning about substance use in Manitoba, and now one of the policies that we've recommended has made it all the way to the Coaching Association of Canada. But that's how I first got involved with research. I thought, I need to do something clinical. There's something that I can do as a pharmacy student or as a pharmacist that no one else can do. And I was looking to figure out exactly what that was. So I identified opportunities. I applied at Health Sciences Center to work as a pharmacist assistant, along with a couple of my colleagues, a couple of my classmates from school. They ended up getting drug distribution related tasks, and because I had done my previous work in research over the past summer, I was accepted to do a project on medication reconciliation through the main pharmacy. And so my project had to do with medication reconciliation, specifically in pediatrics at the time of discharge. And when I first walked into the office, the senior pharmacist who ended up being my supervisor sat me down. I'm sitting there on my first day, and I'm thinking, okay, well, I've never really been in a hospital setting for this long. And I look at my watch, it's been about 5 minutes. And I was thinking, this is all very new to me. So she asked me, what do you know about medication reconciliation? And I just looked back at her and paused and thought about it. I was thinking, I don't know anything. So I told her, I know what medications are. And she was like, okay, well, that's a good start, but it sounds like you're going to have to do a little bit of research here. So my first week on the job was spent doing literature reviews and speaking with the physicians, nurses, and pharmacists who are currently involved with the discharge process and with medication reconciliation in the hospital. So that's how I learned a little bit about the current status, what Health Sciences Center in Winnipeg had to offer. Some parts were better than others. The admissions process was starting to look better and better. They'd been working on it for about 2 years, and that was going well. The transfer process was getting underway, and the discharge process was, at this point, virtually untouched. And I was a little surprised by that because I definitely thought that medication reconciliation just happens. I thought that a patient comes in with certain medications, they go out with the right medications, and everybody's happy. Obviously, we're here today because that's not the case. So what I learned were some pharmacy and clinical related skills, as well as some research and business related skills through this project. So for example, I learned the importance of medication reconciliation. Now, I do know that I'm still a novice. I only learned about this over the summer. But already you can identify problems within a system, and you can see, as a student, what you want to change. But sometimes the idea of the way to get there isn't always evident. I thought it would be. I was naive. I think I'm still naive. But looking forward, I could see that in the future there were different things that I wanted to see change. There were different ways of doing things that hadn't really been explored yet. I also learned how to read a medical chart. I looked at one for the first time over the summer, and there were a lot of papers in there. And I didn't really understand them. There were stamps, and I was looking at it, and I was like, I have no idea what's going on. Luckily, the staff helped me to sort through that. And I was also learning how to read an electronic medication profile with the pharmacy staff. I was very happy that we were using a computer program, because I'd heard from one of my classmates that in another town in Selkirk, Manitoba, they were still using typewriters in the pharmacy department. So we had a little bit of a better time with medication reconciliation than they did, I'm sure. I also learned how to perform an audit. It was my first exposure to clinical audit. This is something that I did not learn in pharmacy school. I definitely didn't learn it in high school. And it was a very unique experience, and I was glad to be a part of that. I also learned how to conduct focus groups, interviews with physicians, nurses, pharmacists to see what they thought we could change. Because not everybody was satisfied with the way things were going, and every time we got a report of a medication error, everyone would just think, we could have done something better. But we didn't have anyone in place to figure out the different changes that could be made. And then that's where I came in as a student. And I also learned how to chair meetings. The staff were very indulging because they would just sit there as I was trying to run through the agenda for the day, and they'd just be like, okay, okay. But they listened. That was phenomenal. It was amazing teamwork, and it made me feel very accepted. I was in a new environment. I was easily intimidated, just as I'm intimidated right now standing in front of all of you who have been healthcare professionals and students. I know that there's some of you here. But you all have so much experience and expertise, and you know what you're doing. And here I am coming into this environment saying, yeah, I don't think that works. And they're looking at me and they're thinking, no, that's how we do things. And I'm like, okay, well, that's what they could have done, I should say. They could have told me, we're not changing anything because this is how we do it. But the champions of quality improvement at the Health Sciences Center were absolutely excellent and were very helpful in integrating me into these processes. So, what do I feel I contributed? First of all, was a new perspective. As we've already discussed before, I'm looking at it from the outside of this institution, looking in. So, I'm a third-party, objective, everything is brand new to me. And the other thing is that I'm looking at it as, from a student's perspective. Again, new, but also with that I think comes something I would like to call the idealism of youth. I'm 21. I'm in the middle of my first degree. I don't even know what I'm doing with my life yet. But what I do know is that there are ways that I think something should happen. Like I said, I thought medication reconciliation happened automatically. Well, it doesn't. But maybe we should find the processes to make that easier so that it does happen every time, so that we do reduce the number of discrepancies and reduce the number of errors. And as a student, I'm thinking, why isn't this already happening? So as a budding professional, I'm thinking, I need to do something now to make this happen. And lastly, I believe I contributed a unique opportunity. This was independent work for the most part. Although my supervisor's door was always open and she was great with answering questions, a lot of the clinical audit was done pretty independently. It was on my time. I wasn't kind of subservient to her schedule. I was able to do it myself, which was excellent. And I was also able to fully devote both my time and my effort to the project wholeheartedly over the summer. I didn't have anything else to do, so it was a really good opportunity for the institution, bringing someone in who would have this kind of time and capability and the eagerness to do so. So just a short example. This is what I thought the medication reconciliation decision-making process would look like at the time of discharge. I thought, hey, cool, linear, right? You make one decision, then the next, then the next, and then you're good to go. You can discharge them right away. What I didn't realize at the time was that it's a little bit more involved than this, and just a little bit. And I learned that there were different types of discrepancies. Now, this wasn't something that I had thought about consciously before. I mean, it's common sense, but sometimes there are medications that are omitted. Sometimes there are medications that are added on. Sometimes they're not adjusted properly. Sometimes they're just in hospital and they're supposed to return back to the original dosing, but they don't. And these can all impact the patient in a negative fashion. And sometimes when those omissions, those discrepancies are missed, we get lucky and the patient doesn't experience an adverse effect. But we can't rely on luck all the time. So coming back to the flowchart, one of the components of my project was to flowchart the process of medication reconciliation at discharge, and this was just specifically in one intermediate care pediatrics unit. So I thought, okay, great, it's going to look like this. This was my first draft. This won't be on the test, so it's you don't need to read every section. And besides my propensity for enjoying making really complicated flowcharts, this revealed a very key problem, and that was that we don't have one unified process. So I thought, okay, maybe this needs a little bit more work. So I figured that what I would do is isolate the pharmacist's role, physician's role, and the nurse's role. And then I would get probably a simpler diagram, because this was trying to incorporate too much. I couldn't possibly fit it all on one page. So then I moved to pharmacists, and I found it didn't get very much better. These were and this was just pharmacy alone. So again, we're looking at a lot of divergent pathways, and the same was true for nurses. So from that, we were able to, I was able to work with my supervisor, and we came up with strategies that we could implement. Part of that was converting to an electronic discharge process, and a lot of that was more open communication with, between healthcare professionals. It didn't make sense that they were all based at separate parts of the hospital, even though they were working with the one patient. And working on this unit was particularly interesting because it was intermediate care, and they saw a lot of returning patients, for example, cystic fibrosis patients. There was a very good relationship, and so there was a very strong desire to help these patients because that relationship had been built. I mean, I know that in general, we should be saying we should always have good relationships. We should always want, we do always want the best for our patient. But sometimes there's just something about having a patient come back time and time again where you want to optimize what you can do for them, what you can do to improve their health. And so I found that a lot of the healthcare professionals I was working with were very receptive to ideas. Obviously, they were telling me when things were impossible, and that was great too. But that's the sort of relationship that has to be made between colleagues and with their patients, so that we can improve patient safety and patient healthcare as a whole. So again, that was a summary of how I got involved, what I learned while I was doing it, what I contributed, and how I feel that not just myself, but all students are able to contribute in some way to quality improvement. Thank you.
So please help us for a moment. We are searching for a practical guide that can list the different kind of things that the student can do to contribute to a better value in our services for the patients. After you have put down 3, 4, 5 ideas, also discuss with your neighbor, what do you like to ask the students? And then the third thing we should do is to talk a little about IHI School. But please now, 3 minutes, chat with your neighbor. What can a student do? And when you have listed some ideas, we appreciate a lot if you put them in this box when you leave the room. So let's take 3 minutes. Chat with your neighbor. Okay. Let's see. You can keep on listing your ideas while we now have questions to the students. I saw that we had one question down here, but I don't know where she went. Where is she? Yeah, exactly. Question to the student.
I just wondered if any of you encountered barriers from providers who felt that there were issues with you observing patient care, patient information, or provider activity.
Well, to repeat the question, it was to the students, did you ever encounter any difficulty from providers who were objecting to you observing their processes and just observing them in action with patients?
When I was in the operating rooms, I found that often the surgeons didn't quite realize who I was, which was really, really good, because then it meant that they would give their opinions just like free, and I would quickly jot them down. The nurses were always really, really, really accommodating, and I always found that everybody was, once they found out who I was, they were more than happy to have me there. There were various jokes at my expense, but generally they were happy to have a student there and to help me out with my project.
Anyone else?
I've actually found the opposite of resistance. I've kind of found that if I'm taking notes, it's like, oh, let's give her anything else we can give her, and maybe it'll get back to someone else. So I find that if I'm there to study how long it takes to move a patient, then they're like, oh, you should talk to someone about the schedule. And I'm like, oh, that's not what I'm here for. So at least where I've been, folks have been really welcoming, and even I've gotten even more than I've been looking for.
So I really appreciate each of your presentations, and what I found interesting, I'd like a couple of you to comment on is, yes, what you've done as students, but it's not independent just as a student. There was faculty involvement, and there was who sort of helped mentor you through doing this locally. And there was also the care setting, whether it's in the operating room or doing med reconciliation. The care setting was ready to accept a student there. And so I think, as Alexi kind of said, you have some time, but you also, as a student, you can kind of slot into a level in the system that maybe others can't. But I wonder if you could talk about sort of the local support that you had from either faculty or the care setting in helping to make it happen.
Well, mine was actually a university project, so I was assigned to a tutor, and then she helped me get into the meetings that I needed to get into to get information. She was the one who helped me make sure I could get into theatre when I needed to get into theatre, and so I got a lot of support from her. She's a consultant surgeon, but she's also part of the university, which meant that I could get access to information through the university, but also access to information through the hospital. So she really helped that transition into the team and into that sort of almost hierarchy that there is.
For myself, it was, as I said, it was a summer job. So the two people that I really found that helped me a lot were a senior pharmacist who was my supervisor, and we also had a quality control officer who had already begun the initial work on medication reconciliation, as well as a number of other projects such as first dose antibiotics. And it was really the two of them that introduced me to the nurses on this unit that I ended up going to, where they said, these people have said time and time again that there are issues that need to be resolved. And so these people were already receptive to the idea that changes needed to be made. And I think that once our report becomes more public, and once a few other people from other units have had a chance to see it as well, and notice that these changes are making a difference, I think that we'll be able to spread it to the rest of the hospital and beyond that as well.
Yeah, I think this is an important point that's coming out here, that it really takes two to tango when we're talking about these quality improvement projects. And obviously the student has to bring a lot of energy and time and excitement and their fresh perspective and their willingness to work. And then there has to be receptiveness on the other end, someone who's going to open doors, who's going to answer the questions when we don't know what's going on. So I think that's really important. And also, as we migrate from the situation in which all of these students have experienced, where they were slotted into a project that was, or slotted to figure out the solution to a problem that was discovered by someone else. As we move away from that, and the students start saying, "Hey, this is a problem. We want to fix it." We have to create an environment where the faculty is receptive to that, and the leaders are receptive to that, and then create a foundation for them to operate off of. So, like I said, two to tango. I think that's really what we're coming out here. Yoran, there's a question in the back.
Yes, Heather.
Hi, my name is Heather Bennett. I'm a medical student at the University of California, San Francisco. And I appreciate the comments about mentorship. I was actually wondering, given the topic, change from the bottom up, what maybe some of you can comment on have been student-to-student interaction or peer interaction around quality improvement, and how you can sort of get a groundswell going among the student population so that issues of quality improvement and safety are known, because I find that most people that I talk to in my class don't know what IHI is or what quality improvement is. Thank you.
Alexi, are you there?
Yes, I'm here. So I think this is a perfect opportunity really to talk a little bit about the IHI Open School, and then I'll let the students, if they'd like to chime in, they can. I think that student-to-student interaction and peer-to-peer interactions, we're not just talking about students here, is very important. And oftentimes you're right that you may be the only person in your school or in your institution that is interested in this information. So what we wanted to do with the IHI Open School is to create a community where you could interact with like-minded people. So they may not be next door, they may be across the country, but there's somebody who's like-minded, who's in the same exact situation that you are. So we wanted to create a community with the IHI school, and that's what the school is. The school is also it is a school that has a bunch of resources online and in the various chapters around the world that can bring students up to speed. They can give them the appropriate improvement tools, the background, the thinking, the frameworks, so that they can be effective improvers, and that they can develop by working with each other, working with other students. So I think student-to-student interaction is very important, although unfortunately kind of non-existent at this point. And that's sort of the need that we were trying to address with this IHI Open School. Each of these 4 students was, as I said it in our previous session, it just came to me, is that they are blessed with this gene of desire to work in quality improvement, but that's not necessarily the case for everybody else. So they had the motivation and the energy to make it happen, but they need to have a community like the Open School to help them do what they want to do more effectively, but also bring more people into the tent. So that's sort of what the school is. I mean, I'm happy to answer more questions about the school, but I'd really like to allow you to ask questions of the students or share any thoughts that you may have. So, Jorn, did you see any more inquisitive folks in the audience?
No, I have. Yes, there is one more question, but we had one of you that had been into the school. Haven't you that, Claire? Can't you comment that?
That does work. We don't have a chapter in my university. I'm trying to set that up just now, but I have used the IHI Open School website, and I used the online courses before I came. Well, tried to get my way through with the online courses before I got here, as just like a baseline knowledge, and it is really, really useful. I mean, I think there's still some kinks that need to be ironed out. It's a bit of a confusing website. I found it confusing, but then I like simple things. But it is a really, really good source of information. And also, the Scottish Patient Safety Programme has used the IHI almost as an extranet. And I've got a lot of information on there to do with quality improvement that's been shared among other health professionals. And it's helped me get in touch with them if I have any questions.
Alexi, we have one more question here.
Okay, please.
I was curious, when you guys went from your student perspective into the actual healthcare setting, did you have moments where you went, wow, I can't believe that's the way it works, either positive or negative, but what were those things that, I'm actually most curious about the industrial engineer. I'm fascinated by the fact that, having done this for years, I've never seen one in healthcare. And so I'm curious, from your perspective, what was the, oh my gosh, moment? Or what
Everything. I'm fascinated by the payer system, the way things are paid for. I'm fascinated by sometimes that's at the forefront, sometimes it's not. I'm fascinated by the cost. I'm also fascinated by the waste sometimes. Being an industrial engineer, we look to reduce variability and we look to reduce waste, and sometimes that just shocks me. I will say, however, I've enjoyed every minute of it, so it's nothing negative, but let me think on this for a few more minutes about something that everything actually kind of, it's just a completely different world. Oh, one more thing is the thing that I'm really kind of glad to be a part of this is the biggest one, I guess. I'm really glad to have gotten involved with this IHI institution, because I find when I go different places, they report here and they report there, and it's kind of the same thing that Dr. Berg was talking about in talk this morning. There's so many different things that people are doing, and that is a very industrial engineering concept. And, well, why are you doing this? And why do you report to them, but they report to them? And it's very hard for me as an outsider to keep up with who reports to who and why they do this and why they're collecting this, but they're not collecting this. And so from an outsider perspective, it's much larger than I thought. The bigger picture is way bigger than I'd ever imagined it would be, because I walk in and I'm like, okay, I need help classifying patients for evacuations. And this turns into something that I've just never heard of. That being said, though, I have enjoyed every minute of it, and I think it's fascinating the way that it all works, and I think that it's fascinating that folks are working together to even make improvements to it. Thank you for your question.
Justin, did you have a comment to answer that question?
I just wanted to add a little bit from kind of the other the other side of things with the institution itself. Like Health Sciences Center was looking at my project, and at first I think there's probably a lot of skepticism about whether bringing a student on board would actually help at all, because we'd already been, as I said, they'd already been working on it for a couple years, and it was making its way through the institution. But when I did things like the flow chart, which was pretty new to all of us, because it consisted of a number of interviews with each of the different healthcare professionals, we were noticing more and more branches that we didn't know existed before. Until it was all put together, we didn't realize that the pharmacist had all these different divergent pathways, and then it gets passed on to the nurses, back to the pharmacist, over to the physician, like to go back and forth between them. These are all things that we didn't realize, that there were so many different possibilities and really so many different ways that they could go wrong. So I think that by working together and identifying it, it was really beneficial for all of us. For me, it was rewarding because I got to see that I was making a difference. I didn't get to change the whole system in one summer. I didn't make it flawless, but I saw where it was going, and that wasn't something that I would have experienced if I didn't have this project. And as for them, I think that they really started to realize that there were key areas that not only were there needed to be improvement, but where they could see changes being made sooner rather than later.
Yeah, and if I might, thank you, Justin. If I might also just chime in with my own little story. I'm speaking out of turn here, but so as a medical student, I just got onto the wards about 6 months ago, and to me, the most shocking thing is rounding. I don't get why we do it. I spent the first 2 years of medical school sitting in my classroom and being yelled at about how the patient is the most important thing. You got to be with the patient, spend time with the patient. That's what we're here for, the patient. Then I get on the wards and I find out we pre-round, then we round for 2 hours, then we work round, then we have attending rounds. Then maybe I get about 10 minutes before lunch to go sit with my patient. And I find, and I have more time than the interns and the residents and the attendings to spend with their patient. I found that absolutely, utterly shocking, that a system that is purportedly geared around patients spends almost no time with them. And then I found out, I found a sympathetic attending who had done a study. He just he went around for a whole year observing the interns on his teams when he was on service. He found out that, on average, they each carry about 12 patients at a time. In a whole day, they spend 47 minutes in aggregate with all of their patients, and they spend the remainder of their 12 to 15 hours in the hospital in front of a computer, writing a note, yelling at some consultant on the phone. It's just, to me, it was mind-boggling how little patient contact there is and how much, busy work there is. So that was my own kind of wow moment. I think we have time for...
Yes, we have 2 more comments. So, and it's no questions that can be answered, but they can be questions, but they are as comments and reflections. Please, sir.
Well, a couple comments. One is industrial engineering is all about flow, and medical care is all about flow. So everything we do practically is industrial engineering, and we have quite a few at our place. Secondly, several of you made the comments about being used, and the goal of students is not to being used. You are students first. So it's what we owe you, not the other way around. So don't get caught in the idea of being used, because it's not fun. And then my question is, if you have a project and you don't write a paper, is the project a success? And would you be willing to take an F for it if you don't?
Well, Well, so I would just say in response while we're waiting that I think absolutely, first of all, writing about your project is very important. I just had a very interesting conversation with someone who attended the previous session and said that writing, even if it's not published, is a great way to get learning out of your experience because it forces you to condense your thinking and to figure out what you actually learned. And I think every single one of these students said that one of the great experiences for them was getting an opportunity to either publish or present their work because it made them think about what they learned. And in terms of your point about what we deserve from our education, I think, like I said before, it's a two-way street. I mean, we want to you, it might seem like we're saying, use us, but to us, that experience is very exciting because for us, it's the first time. So you're absolutely right. We are students first, but we also think that we can contribute back to the system. So that's an excellent point.
Alexei, one more.
And then we got to go.
So one quick comment. It's delightful to have you four here. If you could have changed your trajectory in your education, when would you have liked to have started to learn about quality improvement? At what level? Kindergarten, third grade, sixth grade, high school? How could you change, or how would you change the system if you could?
Can I go first because mine is different? Industrial engineering starts quality on day one. And I think this is then the fault of maybe a South Carolina problem. I didn't have good statistical training, and this is something also that I'm glad for the opportunity to come to IHI for, is because I'm really preaching the importance of statistics, and I didn't have that training, and it took me until I got to college to learn all about it, but I've since had 7 years of quality kind of courses, but I don't count because y'all are different.
I'm going to be on the wards in about a year and a half, and I'm just started 4th year, and this is the first time I got any patient safety and quality improvement training. I think we need to get it from first year. We get so bogged down with this is the disease, this is the epidemiology of it, this is how you treat it, and we kind of forget about the bigger picture. And I think as medical students, we need that from day one, because patient safety, we're there for the patients, no one else, really.
Alexei, we are running out of time. So what do you think we should say? I would like to comment that question with the school in Sweden that got Malcolm Baldrige Award this year. They had on the walls fishbone diagrams that the children had made over how the environment were at the schoolyard, how they thought it was in the dining room, but they had no idea that it was quality improvement. So that was just my reflection. Alexei, what is your final word now?
My final word really is thank you all for coming. I think that this is a very important topic. I want to thank also all 4 of these students for volunteering to take the time, and also for all of them to travel a very long way and share their experiences with us. I hope that you'll join us in this movement to get students involved, to get people on the front lines involved. I think bottom-up change is very powerful, and I hope we've given you a little bit of a way of thinking about how you might involve students. I hope that you go home on Friday and think about how am I going to get a student involved in my improvement project. So thank you all for coming.
A warm applause to the students. Thank you.